So it's my great pleasure today to introduce our Grand Round speaker for today. Dr. Jackie Kalinsky is the director of the Preventative Cardiology program here at the Medical College. She is an associate professor and also has an appointment in the Graduate Medical School of Biomedical Sciences. Dr. Kalinsky earned her medical degree here at the Medical College of Wisconsin, which I didn't know that before, and then did a
and bronchitis. But there were no differences between groups in terms of liver muscle or hematologic labs or parameters. And then this group did do, they did do this patient level analysis of, again, all the phase 3 trials and looked at cardiovascular events and did see a reduction in MACE, but not, some of the components. They're not fatal and non-fatal MIs or fatal and non-fatal stroke. But at least it tells us that there likely is potential cardiovascular benefit. I would say I'm not surprised. Anything really that seems to lower LDL seems to lower risk. But at least we have some data. Now, what does this cost to the patient? Well, currently we know that a single dose is $3,800 without insurance. Now, the difficult thing about inclisiran is that it goes through medical insurance, not prescription drug insurance, and that's because it has to be administered in the clinic. I'm not sure exactly why that is the case, but as of now, to prescribe it, it's got to be dosed in the clinic. So this increases the complexity. We can't tell the patients what it's going to cost them, but what we do is we do provide them with certain codes, specifically a J code and CPT codes that they can call their medical insurance with and get at least some sort of cost estimate for inclisiran. Now, this is in comparison to our monoclonal PCSK9 inhibitor antibodies, right? So our Praluent and our Repatha. These over 96% of our patients can afford these now. When we combine copay cards with insurance and cost of these medications coming down, they're very affordable right now. So, our approach in my clinic is been, if they're doing well on these PCSK9 monoclonal antibody inhibitors, there's really, at least not right now, no reason to switch them to inclisiran where there's a lot of unknowns still, especially in terms of cost. So that said, some of the current folks that are on inclisiran right now, one example, I have a 50-year-old woman with gene-confirmed FH. She's on high-intensity statin and ezetimibe, but has had allergic reactions to both PCSK9 inhibitors and has a current LDL of 200. So she just started inclisiran a few months ago. And then we have another one is a 60-year-old woman, again with FH, intolerant to statins, ezetimibe, and high-dose PCSK9 inhibitors. So she actually tolerated the lower dose of Praluent, but her LDL is not at goal, so we switched her over to inclisiran. She seems to be doing well on it. And then one other example that comes to mind, I have a 60-year-old man that has clinical ASCVD, statin intolerance, is only on Zetia, and he cannot perform self-injection. So he can't do his own, PCSK9 inhibitor, monoclonal antibody inhibitor injections due to an essential tremor. So he's on inclisiran as well. My advice to you for starting this, so it was a logistical nightmare to get it going in our cardiology clinics, but now it's there, now it's happening, just at CFAC. But we have a protocol for it, so if you're interested as a division, I can always send that over to you. But for now, if you do have somebody that you think might be a candidate, please do refer over to us and we can get them going on it. Just remember, the big thing is this because it is a PCSK9 inhibitor, this is not an add-on therapy to somebody that's already on Praluent or Repatha, right? They will not work together. Or there won't be additional LDL lowering. While inclisiran is likely more convenient for a lot of patients, I think in terms of cost, it's still not preferred over what we currently have. Another interesting thing, so as of July of this year, the FDA expanded approval of inclisiran to include high-risk primary prevention patients. So no ASCVD, no FH, but they are high risk, say by the pooled cohort equation, for example. So this is a different, especially since our monoclonal antibodies inhibitors don't have this approval yet. But we'll have to see where this goes. I think right now it's a matter of payers and what they're going to do with this medication. Bempedoic acid, so we do have another tool in our pocket here. So this is the CLEAR Outcomes trial published this year. Bempedoic acid, it's an ATP citrate lyase inhibitor. It's also an inactive prodrug, and it doesn't get activated until it reaches the liver. So because it's a prodrug, it's not supposed to result in myalgias or lead to myalgias or be associated with myalgias. And in fact, at least in the CLEAR Outcomes trial, there were less myalgias with bempedoic acid compared to historically compared to statins. So this was all in patients that were either unable or unwilling to take statins. So a very statin intolerant population. But this one, you know, kind of like ezetimibe, you know, modest reduction in LDL levels, about 21%. But still, it's something. It's still another option. It seems to be well tolerated in general. You know, I still think there's a role for bile acid sequestrants in some patients, particularly in pregnant women who already have ASCVD, maybe have FH, and you don't want to, you know, not have them on any LDL lowering agent during pregnancy. It's safe during pregnancy. It's also safe in children and approved for use in children. All right, so these are two groups where, you know, when you have LDL, it's not at goal and some mixed in with some statin intolerance. So on the left here, we have our secondary prevention. They basically, you know, are eligible for any of these medications. And I don't spend a lot of time on the LDL apheresis during this talk, but it is an option. It's always an option for secondary prevention, and it oftentimes is easily approved and covered by insurance. You know, the big problem is that people just don't want to do it. It's a huge inconvenience. You know, they have to get 2 IVs put in. They have to go every couple of weeks to have the LDL pulled out. So it's hugely inconvenient. And then on the right here, we have our primary prevention without FH group. You know, so if they're not tolerating statin, there's Zetia, there's bile acid sequestrant, maybe inclisiran, though I don't think payers are going to come around with that approval quite yet. What I will say is that in some of these primary prevention patients, CAC has helped. So we have been able to get PCSK9 monoclonal antibody inhibitors approved in primary preventions that have CAC in some cases. So always think about that if you're running into issues with LDL lowering in primary prevention. All right, so lipoprotein A, this is I shouldn't really call it the new kid on the block, but it's maybe like the more popular kid on the block right now. So we've known about Lp(a) for a long time. What is it? So it's an LDL-like lipoprotein, but it has an apolipoprotein A bonded to ApoB100. It's small, it's atherogenic, it gets into the blood vessel wall. 90% of lipoprotein(a) levels are inherited, and they reach adult levels by age 5. It's estimated to be elevated in 20% of the population, so that's not a small number. It's an independent risk factor for ASCVD, so independent of LDL. It also is causal in valvular aortic stenosis. Furthermore, environmental factors do not appear to impact levels, so there's not much to do from a lifestyle standpoint that can really put a dent in lipoprotein(a). Furthermore, statins do not affect levels. Niacin does decrease lipoprotein(a) to some extent, but we all know that it does not affect cardiovascular disease outcomes, and currently it is not recommended as a treatment for high lipoprotein(a). PCSK9 inhibitors lower lipoprotein(a) a little bit, maybe 17%, but I'll show you why that's probably not enough. So Lp(a) and secondary prevention, why do we care? So if we have somebody that we're already maximizing or optimizing treatment for secondary prevention, why do we care about lipoprotein(a)? Well, what we've seen from this pooled analysis of 7 RCTs was that elevated lipoprotein(a) in statin-treated patients still signifies increased risk of major adverse cardiovascular events. So it's something that we currently don't have a good treatment for, but it's causing problems. This is data from Odyssey. So remember, this is one of the PCSK9 monoclonal antibody inhibitor trials, the large trials. Here they looked at the proportion of MACE reduction that was attributable to LDL versus lipoprotein(a). And what you can see that in those with higher Lp(a) levels, some of that risk reduction, 27% of the risk reduction was related to lowering lipoprotein(a) in these folks. So more reason why lipoprotein(a) is a really hot target right now. Testing here in your clinics, if you're going to do it, pay attention to the units. So the majority of professional societies prefer the nanomoles per liter. Unfortunately, we've got the other one here. We're working on changing that, but we've got the milligrams per deciliter assays at most of the Freighter clinics. So what is considered high or abnormal? So if it's over 50 milligrams per deciliter or 125 nanomoles per liter. These levels correspond to the 80th percentile in populations which are predominantly Caucasian. African Americans and South Asians often have higher Lp(a) levels compared to Caucasians. The testing does not require fasting. Results are affected by inflammation. So if somebody, has a virus or a cold, or, if somebody's actively in the hospital with a stroke or a heart attack, that's not the right time to test for lipoprotein(a). It'll be high because of inflammation. But otherwise, it's a fairly easy test. I haven't had many issues in the last several years with insurance not approving it. So, current guidelines suggest, hey, at least test this once, especially in patients with a personal or family history of premature coronary disease, because there is that, it's inherited, right? It comes from mom and dad. Some guidelines even say, consider testing at least once in everyone's lifetime. So in my clinic, I'm doing this almost in everybody, except maybe some of my older folks that are primary prevention still. But just about everyone I test at least once. I don't really retest after that because we don't have targeted therapies, but we will have them soon. So the interesting thing about so Lp(a), so it's not a bell-shaped curve like LDL, right? So it's a very skewed curve in terms of range of Lp(a) levels. So what this means clinically, I'll give you an example here on the right. So lowering Lp(a) 52 points, for example, is needed to achieve the same risk reduction to lowering LDL just 18 points. So we're more interested, for treatments and medications that are going to really, really drop those Lp(a) levels. At this point, 50% reduction or 40% reduction that we do with LDL is not going to be the same thing. So there are several investigative therapies on the horizon to lower lipoprotein(a). So in the box on the left here, there's injectable RNA-based therapies. These RNA-based therapies are really hitting the ground running. So there's a couple of different ones. There's antisense oligonucleotides, and then of course the small interfering RNA. Shown here is a couple examples of the different names of these drugs. And then on the right here, we actually have an oral small molecule inhibitor therapy that's being tested right now called muvalaplin. This was just published, so this is just a phase 2 study of oral muvalaplin on Lp(a) activity, and they were able to achieve 60% reductions in Lp(a) with this oral medication, and that was achieved after just 14 days of treatment. Olpasiran, so this is a small interfering RNA. Similar to inclisiran, right, except that it's targeting Lp(a). The phase 2 study is done. Look at these reductions though. So remember 65% for the oral agent. This is an injectable one. 98% reduction in lipoprotein(a) levels. So they are basically normalizing Lp(a) levels with this drug. This is typically again, every 3-month injection, which is another, I think another benefit. And efficacy and safety was shown in these phase 2 trials. Right now, there's a phase 3 trial ongoing. It's multi-center. I'm sad to say that we're not part of it. However, there is many sites across the country, 3 sites in Chicago. So I have referred, I just referred my first patient to this outcomes trial at one of the Chicago locations. He's a 48-year-old man that had an NSTEMI a few years ago, so in his early 40s. He has FH, and he has an LP(a) level that meets requirements for this trial. So we'll see how that goes. I'll keep you posted. I'll wrap up here very soon. I know we didn't talk about triglycerides at all today. It's a bit much, but regarding these mRNA technologies, there's also some that are under investigation for lowering triglycerides that target this ANGPTL3 protein. So those are also on the horizon, and the ApoC3 as well. But I think this mRNA technology has really transformed the field of lipidology in a really good way. So I'm going to stop there, and we're going to skip stand intolerance today, but I do just want to make sure that there are time for questions. And then here's my team. So I think most of you know Dr. Welsh. She has clinic at Mequon and Freighter West Bend. Maya Safarova just joined us in August. She's fantastic. She's interested in genetics and lipids, the genetics of premature coronary disease. Aaron and Zach are phenomenal pharmacists that have been working with me since the beginning and are very good at managing lipids and stand intolerance. And then Lana Zaharova is my nurse practitioner that helps see a lot of my patients in follow-up when I'm not available. We also collaborate with Versity Blood Center for apheresis, the genetics team for FH testing, and then nutrition services to help with plant-based diets, etc.
Great. Thank you so much. Great talk. I see we already have one question. So Brad was wondering, with CAC scores, do they improve with statin therapy, and do you follow CACs after you start therapy such as statins?
Oh, that's such a great question, Zach. So my rule of thumb, and I think a lot of us agree with this in cardiology, is that if the first CAC score is positive or abnormal, that there's really no role in repeating it. Part of the reason is that, remember, the CAC score only gives you the burden of calcified plaque. Now, we know from autopsy studies that and NCT coronary angiograms that most people have a combination of calcified and softer lipid-rich plaques. They often travel together. But part of the way that these medications work is it depends on the stage of the plaque. So if the plaque is lipid-rich, it may end up just making it more calcified, which stabilizes it and prevents it from rupturing. Or if it's early on in formation, then it can dissolve it a little bit. But what you'll end up seeing is that, the CAC scores will likely go up, partly because plaques are becoming more stable and more calcified on some of these therapies. And then the patient will just be disappointed. If you check and it's going up, they'll be disappointed.
Great. Joe, looks like you have a question. If you have a question, feel free to unmute. Go ahead, Joe.
This is Joe Shaker. Thanks, Jacqueline. That was fabulous talk, and from someone who doesn't take care of patients with lipids and doesn't know much. But your first slide, or one of the first slides about the 80% reduction is interesting. Is it really prevention or delay? Because ultimately we die of something. And if it's a delay, is it 10 years? In other words, of those 80% that we prevent, I assume that they're going to die of heart disease or stroke or something unless they get cancer at some point. Right. And how far is that delay? Or is that does that question make sense?
It does. It absolutely makes sense. It absolutely does. Because yes, we all die of something. I think I think the goal, that's why, I showed that life course of cardiovascular disease, because I really think the earlier that we can address these things, the better off the patient is, right? The earlier they can make those changes. And I think really the goal is it's not quantity, right, of life, it's quality of life. And so I think even in older ages, checking those 8 boxes will still lead to higher quality of life and probably less time on the end suffering, and less time in those years of life that don't have very good quality. And I think the AHA, when they do their annual heart and stroke statistics report, that's kind of what they touch on, is more kind of quality of life.
That's a great answer, right? And I think it makes complete sense. I have a quick follow-up question that I don't want to take too much time up, but the dialysis patients, the studies that I know of on statins have not shown efficacy. Yeah. Is that just because they just die no matter what?
Yeah, that's such a tough population. So you're absolutely right. So the studies that have looked at statins and even primary prevention for dialysis patients have not shown benefit. And I think you're exactly right. I think some of that is competing risks. So that being line infections or electrolyte derangements leading to other problems. That's at least part of it. The other part of it is that even though we know that they develop coronary artery disease, and a lot of calcification, it seems like it's a different process, right? And it seems to be more related to whatever's getting dialyzed through their system in a way. And so the formation of plaque in these patients appears to be different, right? Or from a different process. And maybe that's also why statins aren't beneficial in that group.
That's a good point. I know Denise has a lot of expertise in this, but they get calcification and actually ossification in their vessels. So I suspect it is different. Thank you.
You're welcome.
Jacqueline, this is actually Denise, and I have a question for you. I started ordering more Lp(a), but in some of my patients, insurance is denying, saying that it's an experimental assay. What can I do for that test to be covered?
Oh gosh, that's now they won't let you check it more than once oftentimes, unless they're getting apheresis. By the way, Lp(a) can get apheresed off. But maybe pay attention, Denise, for me, if you don't mind, pay attention to which insurance payers they have, because 10 years ago, I was seeing one payer that was making it a problem, and then I haven't seen that in the last 5 or 6 years. I think that they've come around, so I haven't had anybody not approve it. The other option is that you can write like a paper script or whatever, print off a paper script and have them go to some of these independent labs, and sometimes they can just pay $25 to get lipoprotein(a) tested. So that would be another option. I know at Freighter, they charge, I think it's $100. And so if it's not being covered, then that patient's going to get a $100 bill for lipoprotein(a).
Yes, that's exactly the point. There were a couple of patients from Freighter UMR that is not being covered, and they're trying to appeal. So if you have any information that you can share with me how to help, please email that to me.
I will. I'll look into that, Denise. And yeah, and certainly. So it's UMR. You said it's our own. It's our own.
It's our own. Yes.
Bummer. Okay, I'll look into that.
Thank you.
Great. Lisa, looks like you've got a question.
Yes, thank you very much for this great review. That was really informative. I was wondering, how often do you need to prescribe the higher dose of PCSK9 inhibitors because the patients don't have enough LDL reduction with the lower dose?
Great question.